Okay, so we are super excited to be sharing about both MeBe's ABA services and Texas Medicaid. We have been working really hard, throughout the state to be able to provide ABA services in Texas so that they are covered by Medicaid for a long time. And so that's what we're going to be talking about today. February 1st is when Medicaid funded ABA services started being offered in Texas, but that has been a long road, and we're finding that many families are struggling to find those services that are being offered already. So I want to talk a little bit more about that and help you navigate how to find those services, where they are covered, how you can get them covered, and a little bit more about that. So a little bit about me. I'm Nicole Clarkson. I've been a BCBA for 10, almost 11 years, and I've been serving the autism community for 18 years. Primarily, I've practiced in Houston, so I know this community really well. And I also worked in East Texas around Nacogdoches for about 4 years when I was in undergrad. I'm very excited to talk to you about Medicaid and MeBe services. My daughter was born at 26 weeks, so we navigated the Medicaid services world very early on when she was younger, and I know that it can be overwhelming and daunting from my own personal experience. So I'm excited to kind of dive into it with y'all today. So topics that we're going to cover include what is ABA, just an overview of it. I hear from a lot of parents that they get a diagnosis of autism and they're told, go get ABA. But what is ABA and how is it helpful? And is it for everyone? And how do you get it? We're also going to talk about an overview of Medicaid benefits and what the qualifications are, referral assessment, authorization, and the reevaluation process as it refers to Medicaid-funded ABA services, what ABA services at MeBe look like and how you can acquire those, as well as have that question and answer period. So what is ABA? ABA is applied behavior analysis. It is a science with decades of literature and research behind it. Applied behavior analysis, or ABA, is a therapeutic approach that focuses on the science of learning and behavior. And sometimes ABA and BCBAs, we can be known to have a lot of big words and kind of be off-putting, but really ABA, we are trying to work on teaching kids the things that we want them to know. And the research that we have shows that ABA therapy can be beneficial for individuals with autism. And really, ABA can be beneficial for anyone. You don't have to have a diagnosis. It doesn't have to be done in a clinic in really stringent environments. But right now, ABA therapy is funded by either insurance or Medicaid for individuals with autism, primarily individuals who are younger and that have a medical need. ABA therapy is going to increase behaviors we want to see more of. So that might be something like communication. We want our children, our youth, adolescents, and adults to work on communicating with us. What do they want? What do they not want? How can they get those things appropriately? We want them to interact with others appropriately. We want them to engage in play skills, appropriate actions for various environments. And then we want to decrease behaviors that we want to see less of, right? So whether it be maladaptive behavior or rote or restrictive behavior, any of the behaviors that we typically would like to see less of. And something that's really important to me and something that's important at MeBe is, yes, we want to increase behaviors that we want to see more of. And yes, we want to decrease those maladaptive behaviors, but we want to celebrate everyone for the person that they are without changing them. So an example of that would be for some of my clients, they may engage in self-stimulatory behavior, but they're not interested in changing that behavior because that behavior is what defines them or what makes them happy. And that's great. We're not going to change that for them. And because it's not interfering with them learning, it's not interfering with their social interactions with others. So we're not going to change that. Still for others, they may have identified that this is a behavior that is interfering in their learning or is interfering in the social interactions that they're interested in. We really want to look at individualizing our treatment goals to ensure that everyone is able to find the goals for their children, find the goals for their families that are going to help their children become the most independent, versions of themselves. We're not trying to make people less autistic. We're trying to make them the most independent, functional versions of themselves. And so that's a big thing about, progressive ABA is that we're not trying to change people's lives in that we're trying to make them less autistic. We just want to help them have healthier, happier, safer lives. And so that's a big difference when looking at different ABA programs, as well as really looking at what are the goals that they're looking at. And additionally, ABA funded through Medicaid is not necessarily appropriate for all individuals. Some individuals may need more restrictive treatment, and that maybe they need more care. Maybe they're needing a residential treatment facility, or they're needing something where they're observed more often, or they're needing less care, or maybe they're just needing a different approach altogether. ABA therapy through Medicaid must be medically necessary. What I mean by medically necessary is that there are specific guidelines that both your doctor, primary care physician, psychologist, developmental pediatrician, and your behavior analyst have to meet and have to indicate that this treatment is medically necessary. We must be treating the core components of autism, and we'll talk about that a little bit more later, so that it is medically necessary. There are things that your child may need to learn, or skills they may need to know, or may need to develop, that are educationally needed, or that would help them in life, but that are not considered medically necessary, which as a parent and as a practitioner can be frustrating. But because it is medically funded, we have to go off of a medical model. ABA therapy through Medicaid is typically implemented in a clinic or home setting. However, through clinic-based or home-based programs, often you will see that we will then be going into the community, because we've learned these skills in the clinic, we've learned them in the home, and now we're working on some social-based skills, or maybe we're working on tolerating the dentist, or we're going to a play-based, activity, so that we can work on tolerating sharing, or working on those social skills we've been really, really hitting hard at home, but we need some peers to work on with them. ABA therapy also must be prescribed by a licensed physician or psychologist. So you cannot just take your diagnostic evaluation and maybe your interest in ABA and say, hey, I want ABA therapy. You have to have basically a referral and or prescription from your physician and psychologist that says, I recommend that this child receives X number of hours of therapy per week. It can be a range, and it can be collaboration between your doctor and the BCBA to determine what's most appropriate. And that's typically what we see. There is a form through Texas Medicaid that the doctor will fill out every time there is a reevaluation period that you work with them on. So that is something that they want to make sure that there's collaboration between the team. Now, Medicaid through ABA therapy through Medicaid rather, does exclude school shadows or aides. It does exclude respite care. It does exclude academics as part of ABA therapy or custodial care. Now, something that's really important is that children that are receiving care through Medicaid may have all of these things as components of their Medicaid funded plans, but not through ABA therapy. So they may be getting in-school support, they may have a paraprofessional, but it wouldn't be part of their ABA therapy. So if they're getting ABA therapy through MeBe would not provide an in-school shadow. Their in-school shadow, in-school support paraprofessional would be provided by their school district. So the funding or the training for their paraprofessional would be provided, if appropriate, and if their IEP calls for it, through the school district. So what they're stating is ABA is medically necessary. It is a medical model. And so it is outside of the scope of the school district, or outside of the scope of needing to be involved in the educational needs of your child. So they're very different and very much separate. So service providers in ABA, at least at MeBe, are going to be, here we have a regional director, which is me. We'll have a team of board certified behavior analysts who oversee registered behavior technicians, and they are the ones who are doing the inline therapy. A little bit more about that is that treatment is overseen by a BCBA, which is a board certified behavior analyst. And in Texas, they're also licensed behavior analysts. A BCBA is required to have at least a master's degree. They may also have a doctoral degree. They are required to go through rigorous coursework, significant amount of supervised field work, where they are mentored, they are overseen implementing both direct work with clients as well as indirect work, and then they must pass an exam. They also have to undergo continuing education every couple of years to recertify. In the 3-tier model, you may also have a BCABA, a board certified assistant behavior analyst, who's going to be licensed at the assistant level in Texas. And they may also be members of the treatment team who's going to assist the BCBA in overseeing your child's treatment. They're also going to undergo they have a bachelor's level of education. They're also going to undergo supervision, rigorous coursework. It's just going to be lesser intensive than what is required of a BCBA. Treatment is going to be implemented by one or more behavior technicians on your child's team. Now, as seen here, your child is likely only going to have one BCBA, one board certified behavior analyst, but they're going to have likely 1 to 4 RBTs depending on the number of hours that they have. The reason that I like to have more than one RBT on your child's team is because we want them to get used to responding to multiple service providers. Everybody's going to say things a little bit different. I might say, hey, which one of these is blue? And the next person is going to say, show me the one that's blue. And we want them to be able to respond to people who are asking for things a little bit differently or who respond a little bit differently. We want them to generalize. We want to make sure that their skills are durable over time. And we also want them to just be used to being around different people. So it's important that they have a robust team. We also offer, and it's part of our ethics, that we are doing supervision at 10 to 20% of your child's total hours. So if, say they're receiving 30 hours per week, your BCBA should be seeing them 3 to 6 hours per week. So the BCBA should either be seeing them in person or via telehealth to provide program modification, updating their targets, updating their goals, updating their behavior support plan, as well as providing support, guidance, and feedback to the registered behavior technicians to ensure that they're implementing programming right, answering any questions, saying, hey, do you have any feedback on what goals are going really well, what goals might need a little bit of tweaking, because they are the ones that are there with them most often. RBTs under the Medicaid model are not permitted to implement therapy via telehealth. So especially during COVID times, we saw that for some individuals, you may have the child receiving therapy via telehealth. That is not something that is allowed within Medicaid. Medicaid does require that all behavior technicians are certified either through the registered behavior technician, which is by the BACB, which is going to be the most common, or the BCAT, the board certified autism technician, or the applied behavior analysis technician, the ABA team. So those are the 3 that they will accept. They must be certified prior to providing therapy or treatment to your child. So these are the service providers that your child would be seeing within the Medicaid model. So qualifying for ABA coverage with Medicaid. So these are directly from the Medicaid guidebook. So who qualifies for the new ABA benefit through Medicaid? So your child, youth, adolescent, or adult must be younger than 21 years old. So they're going to require that they're 0 to 20 is exactly what they'll say. Typically, we see children that are diagnosed between 15 to 18 months at the youngest. So we have seen provisional diagnoses at 12 months, typically when they have a sibling that has a diagnosis. You must have a referral from a licensed physician or a licensed psychologist that has signed off on it. They will also take some other diagnoses. I've seen diagnoses from like a DO, from neurologists, and various other doctors. You can refer to their guidebook for those diagnoses, but they would like a comprehensive diagnosis, and we'll talk more about that later. This is extremely important. Your child must be enrolled in an EPSDT eligible program, which is early and periodic screening, diagnosis, and treatment program. So in Texas, that is Texas Health Steps or Texas Health Steps Comprehensive Program. CHIP is not currently eligible for this benefit. So this is common across all states. CHIP was developed for individuals who are not eligible for either their parents' insurance or it's not affordable for them. So it is another benefit. However, Medicaid is this benefit is only available if you are in an EPSDT program. It is not available to individuals who have CHIP at this time. In addition, you must have a medical diagnosis of autism spectrum disorder. What I mean by medical diagnoses is if your child has only been diagnosed within the school district or within the school setting. So if they were diagnosed through like Child Find or the Early Childhood ECI program and then went into the school district for like PPCD or ECI, that is not going to be sufficient for Medicaid. They will need a comprehensive diagnostic evaluation, and it must have been completed within the last 3 years. Additionally, the CDE, the Comprehensive Diagnostic Evaluation, must include the severity level from the DSM-5, which would say if they were mild, moderate, or severe, level 1, 2, or 3. Confirmation of the previous diagnosis is accepted. So say that your child is now 12 and they were diagnosed at 2. They could have a CDE that says, child was originally diagnosed at age 2. They were recently seen at 12 and the diagnosis was confirmed. A confirmatory diagnosis is going to take less testing and paperwork than an initial CDE. So that is accepted, but they would need that date of initial diagnosis in there. And again, we'll talk a little bit more about that in a couple of slides. So here are the treatment guidelines that are specifically from Medicaid. So there are 4 tiers. Now, it is up to your program and your BCBA to really help guide you in what they think is most appropriate to request. It is possible that your child fits multiple frameworks, or maybe they are younger but new to ABA, older, fits multiple. There is high frequency intensive behavior intervention, moderate frequency intensive behavior intervention, targeted focused and intensive behavior intervention, and maintenance and consultative intensive behavior intervention. And high frequency, we're looking at greater than 20 hours per week. I believe that means actually less than or equal to 6 years. They're looking at level 2 or 3 autism, and specifically goals related to severe maladaptive behavior, such as elopement, aggression, or self-injury that are severely impairing. So really looking at individuals that have significant needs and primarily are in the first 2 years of ABA. Research is going to show that the younger you are when you get treatment, and the more intensive that treatment is, the more effective your treatment is going to be. However, if your child is older, if they have had ABA for a little bit, that does not mean that you should not still pursue ABA. ABA can be effective with all individuals. So I still encourage you to reach out and to seek out treatment. It just may be that your child is not a fit for 40 hours a week of ABA. It's rare that I'm going to, refer a 20-year-old individual for 40 hours a week of ABA. But I have individuals who are adolescents that have high needs that are getting 30 hours a week. Now they're getting 30 hours a week for short periods of time while we're doing intensive parent training and we're titrating those hours. But these are a guide and we're working with Medicaid on what is most appropriate for each individual. Their needs are individual, as is the guide. For moderate frequency IBI, we're looking at 6 to 20 hours a week. They're typically 6 to 13 years old, but they may be older. Level 2 or level 3 SD, so higher needs. And their goals are related to elopement, aggression, or self-injury that's moderately impairing, and it's typically within the first 4 years of ABA. And the target or focused IBI, 5 hours a week or 20 hours a month, or it could be less. They may not need as much. And this could be any age or any range of needs. And they're going to focus on specific targeted clinical needs or goals related to specific targeted skills. So it may be that there are only a few things that this individual needs to work on. And so they have few goals that they're intensively working on, or they have maybe a few functional communication goals that they're working on across many environments because they're just working on generalization. Now, for the maintenance or consultative IBI, it may be that, again, like in targeted or focus, they're working very consultatively on, hey, this child is really struggling in this one area or this one environment. It's really impactful for the child, or it's really impactful for the family. Okay, we're just going to consult with the parents and provide parent training, or we're going to provide, behavior support plan for this environment. Or it may be an individual that has had high frequency or moderate frequency behavior intervention in the past, and now we know that if we pull out too quickly, they do show regression, and so we are going to provide consultative services, and this is typically 2 to 4 hours a week, but they did discuss that this could be even less. It may just be 2 to 4 hours a month, and this could be all levels as well. Now, they specifically are wanting a documentation of substantial risk for regression after completion of one of the higher levels of more intensive ABA. So these are their treatment guidelines. Now, again, these are guidelines. This is the framework, and this is a new program. So we are going to use these as a guideline and as our framework. But if we have clients that are not fitting within, or individuals rather, that are not fitting within this framework, then we're going to make the case that they need more intensive or less intensive therapy. One thing that is important is if I am assessing an individual and maybe they're 5 and I'm recommending 30 hours a week, but parents are saying, well, we can only be available 5 hours a week. As a practitioner, as a clinician, I am still going to recommend 30 hours a week and state that what is most clinically appropriate is 30 hours a week, because that's what I would prescribe, just like your doctor would continue to prescribe what is most appropriate, even if you were unable to take that medication at that level or conform to that exercise plan, just like my doctor tells me to exercise 5 times a week, and I have not conformed to that plan well. So we always try to meet people where they're at, with the availability with all of the other therapies that they're in, with school and things like that. But we're going to make the recommendation based on what is most appropriate for that child and the level and the needs that they have at that time. Important things to know as a parent, and some things that have been pretty stringent across Medicaid, across all states, is that clients must attend 85% or more of planned sessions. So each month and each authorization period, we are required to turn in attendance logs. So we will state that, here were the planned sessions, here were the canceled sessions, here were makeup sessions. This is the total number of, attended sessions. Additionally, caregivers must attend training sessions during each authorization period and must attend 85% or more of all planned sessions. Now, some parents may say that they can only attend 1 hour a month. Initial authorization periods are 90 days, which is 3 months. If you have 1 session a month and you cancel 1 out of 3, say you've attended 2 out of 3, you are at less than 85%. And unfortunately, that's something that they can potentially look at discharging or not reauthorizing your plan for. So I really encourage you to ensure that you are attending your planned sessions. If you are unable to attend your planned sessions, communicate that with your provider. Make sure that they know. If there are barriers, let them know. None of us live perfect lives. We all know that there are barriers that can pop up, especially in the last 2 to 3 years when we have been living in a pandemic with a lot of things that have happened. So let them know, hey, grandma typically babysits and she has been really sick. So she's been unable to be at home for, the home sessions. I'm so sorry, we've been canceling more often than usual. What are some different things that we can do? And they might say, hey, we could do some makeup sessions. We could elongate our sessions. Why don't we look at maybe moving to the clinic? There's a lot of things that your practitioners may be able to do if you just open up those lines of communication. Additionally, those are things we as practitioners can communicate to Medicaid, letting them know, hey, there are barriers, but we have solutions in place. Like I said, providers are required to submit an attendance log with all authorization submissions. Talking about that, we're going to talk about the referral, assessment, authorization, and reevaluation process. Now, every clinic, every provider is going to have their own process, but much of it is dictated by Medicaid. They have certain guidelines, certain timelines that they're going to go through, and your provider should walk you through everything and likely is going to do most of it for you. But I think that it's empowering to know what the timelines are, what you should be kind of looking forward to knowing what is expected of you. So the initial evaluation is going to be in a skills assessment and a functional behavior assessment. Our timeline here is once we are granted the functional behavior assessment authorization, we complete it within 3 weeks and return it to Medicaid. And then we wait to hear back from them. And as soon as we get that back, we schedule sessions as soon as possible. If we do not have an RBT ready to schedule sessions, then we begin parent training immediately. Typically, we schedule sessions within 3 days. But if that's not possible, maybe we've had an extenuating circumstance, COVID, something going on, then we start parent training immediately. Once you've completed that assessment, you've got your initial authorization. It's an initial 90-day authorization. After those 90 days, which is just 3 months, you're required to turn in a treatment plan note, which is just going to be a progress note. Maybe some of your goals, maybe if they're a little kid, might be, hey, I want them to label common items. I want them to label 50 common items. When I hold up a picture and say, what is this? They say banana. And I want to be able to hold up random items and they label, a variety of items at 80 to 100% across 5 consecutive sessions. And originally they were at 12%, and now they are at 90%. They've mastered this goal. So we've put in a new one. They want to know what their progress is. They are going to want to see baseline. What were they doing initially? 12%. Where are they at now? 90%. Awesome. Here's a beautiful graph. And here is our plan for what's happening next. And then they're going to want to look at an attendance log. After that 90-day extension, so now we're at 180 days, about 6 months from initial treatment, we can ask for a 180-day recertification. We are going to fill out medical necessity forms. Your provider should be submitting all of this. And they may ask you some additional questions. And they're also going to provide a progress summary, which is similar to the treatment plan note, but probably a lot more in depth. And also provide an attendance log of 85% or more for clients and caregivers. Eventually, not after the 180 days, most likely, the plan should be for transition and discharge. And I know sometimes that can be kind of scary, but our philosophy at MeBe and mine as a BCBA is that being in 1-to-1 ABA is not a lifelong goal. We want you to get treatment as long as you need it. But for us, we have a 6-phase fade out plan or transition plan. Where initially we're doing all of the work, and over time we are training our parents more to be able to facilitate and take over more and more of the sessions to where they're able to do more and more of the actual therapy and teaching the skills that their children need, responding to behavior as it happens, as they need to where they're really empowered to be able to run the sessions. Now, I've had kids that have, transitioned and discharged in 6 months. I have had kids that, have gotten therapy for 5, 6, 7, 8 years. It's going to depend on the needs of the child, but our goal should be to transition your child to a less restrictive environment and empower you to be able to teach the skills that your child needs, and also respond to problem behavior appropriately. None of us are perfect parents. My child is the most difficult client that I have, but we want everyone to be able to know that our goal is to discharge your client. And it's a terrible business model, but it is a great thing for your kid to move to that next environment and that next goal. So a little bit more like I talked about the comprehensive diagnostic evaluation. This is something that's extremely important when you are looking at where to have your child diagnosed or where to have their diagnosis reconfirmed. So their diagnosis must have been completed within the last 3 years. It must include the patient's name and date of initial autism diagnosis. I know that sounds really ridiculous to say, but I've gotten multiple reports with no child's name on them. And it needs to say their initial autism diagnosis date. So if it's being reconfirmed, it would need to say, this child was initially seen on blah, blah date at blah, blah place and diagnosed by blah, blah doctor. I saw them on this date and they continue to demonstrate the diagnostic characteristics of autism. They also need to say the level of autism that they're currently demonstrating. Do they have level 1, 2, or 3 autism? Additionally, they need to include all comorbidities of physical health, behavioral health, mental health, and a history of trauma. The history of trauma is something that they talk about quite often in the Medicaid guidebook. They can simply say there is no signs of abuse or trauma, or if there is, then they just need to, very briefly talk about what that might be. If your child is maybe adopted, maybe there is no known history of maybe the first 2 years of their life, they would just speak about that as well. Because I've had a couple questions about that from parents where there's probably trauma, but we don't know what it is. Whatever your situation is, just very openly talk to the doctor about discussing that and displaying that information. Again, like I talked about, educational diagnoses will not be accepted as the only report. If you do have an educational diagnostic report from an LSSP, from an IEP, from an IFSP, so if your child's under the age of 3, they have an individualized family service plan. If they're over the age of 3, they have an individualized education plan. Those will not be accepted, but you can give those to your provider just so they have that information so they can see what are they working on in school, what are ways that we might be able to support them, not take the place of, but okay, if they're working on prepositions, that's obviously a communication goal that they need some support on, and maybe something we can help with. The comprehensive diagnostic evaluation must be signed and dated by the physician or psychologist with a recommendation. The recommendation should state something like, it is my recommendation that Addison Clarkson receive 25 to 40 hours of ABA per week. It can be smaller than that. It can say that she received 25 hours per week. It says she received up to 40 hours a week. It just needs to have some type of recommendation. If it's not clear enough, Medicaid will let us know, and then we will contact the doctor for clarity. We've definitely had some back and forth with some patients where they've let us know that they want clarity or more clear, referrals, more clear prescription. They've fine-tuned what they want, which is not always helpful. And as they learn what they're doing, we also learn. And so we're able to help parents know what to ask for as well. I would definitely plan ahead in seeking that 3-year confirmatory diagnostic evaluation. It can be very difficult finding practitioners within any area, be it Houston, Dallas, Austin. If you struggle to find someone to do your CDE, we have practitioners within MeBe. We have a BCBAD in Dallas who does comprehensive diagnostic evaluations. She will come to Houston one day in the month and she will perform them. And then we also have doctors that we refer out to, doctors that take Medicaid, doctors that take insurance, as well as I can just, give you referrals to get on their list of when they have availability. My email address is at the end of this, and you can absolutely email me if you have any questions at all, or if you need help just finding that CDE practitioner or provider, because I know that it can be really hard to find somebody that has availability. And even if it's okay, no, I need to get on the list for next year, get on the list now so that you can go ahead and start getting that process started. So the assessment process. Once you initiate services with MeBe or another provider, you are going to undergo an assessment process. And much of this is going to be standardized, whether you have insurance funding, your cash pay, or you are going through Medicaid. But Medicaid has some additional requests. So first and foremost, you're going to have direct or indirect assessments. A direct assessment is an assessment where we are going to be directly observing your child, directly testing things. Indirect assessments are going to be things where we're going to be asking caregivers and parents various questions to help us formulate the treatment plan. So some of the direct assessments may be things like skills assessments. Depending on your child's age, we're going to pick a variety of tools to help us guide that treatment plan formation. We're going to look at things like language, communication, social skills, pragmatics. We want to know, what are the skills that your child has? Are there any splinter skills? Are there gaps that we need to cover? What are the goals that they have? what are things that they are really strong in. A lot of our kiddos are super strong in visual perception skills. So we can use those strengths to help us in their areas where they have a little more goals. The biggest area for me that we always work on first and foremost is functional communication. If they don't have the ability to ask for the things that they want, tell you the things that they do not want, like I need a break, I'm overwhelmed, this is hard for me, I need help, then that's the first things that we're going to work on. Because typically developing children, neurotypical children, they struggle with those skills. So our children struggle with that as well. So no matter their age, we start with those skills as a big component of our treatment plan. We also are going to do functional behavior assessments. We're really looking at what are the antecedents to problem behavior or maladaptive behavior. Maybe your child engages in aggression or self-injurious behavior. Maybe they engage in property destruction or elopement. What happens immediately before that? And what are the consequences that occur right after? Are they getting attention? Are they escaping from something? Are they accessing toys or items? Or is it something internally in their body that they're experiencing? And what are those consequences that may be maintaining that behavior? And then we need to do at least one-to-one observation in at least one natural environment. Now, that's something that we do standard across all of our clients, but that is something that is specified in the Medicaid manual. We also are going to do an interview with parents and caregivers. In that interview, we really want to guide us in knowing a lot about developmental history. We want to know about prenatal care and their birth. Was there anything that was atypical? What is your maternal and paternal history like? Is there any history of autism in the family or anything else? Again, is there any history of trauma? We want to identify any comorbidities. Does your child have any other diagnoses? Is there a history of treatment? Are they in speech or OT or PT? Are they in school? Do they have any school services? What language do you speak in the home? Do you speak multiple? What language do you speak to the most? What language do they speak the most? Are there any barriers to treatment? Are there any things in the home that you want us to be aware of? What are any potential cultural, religious, or other, differences in your home that you want us to be aware of? Because we want to make sure that we're the best fit for you. And maybe there's a different person within our organization that would be a better fit for your family. And we want to really make sure that we form the best treatment team for you. And so we want to really identify all of those things throughout our assessment process. And then also we're going to want to review your previous assessments, looking at all of those to form where have you been, where are you now, and where are we going? And we really want the assessment process to not just be a group of people that are coming in and looking at all of the things your kid can't do, but looking at, hey, these are all of these awesome things that your kid can do. This is fantastic. And okay, this is where they were a year ago. Awesome. Look at all the things that they've done in this year. What are your big goals for them? What are your top 3? Okay. What do you feel like are your top 3 challenges right now? And then how can we kind of bridge those gaps? In the development of goals, all of our goals need to relate back to the core deficits of autism, which are going to be communication deficits, which is the development of language, receptive communication, which is following instructions. If I say, which one is a bowl? You can find it. If I ask you to pick something up that's blue, can you do that? Expressive language. Do you have spoken words? Do you use sign language? Do you use a speech generating device? Do you use gestures? Do you lead me by the hand? How can we get you to use functional communication no matter the modality? Social skill deficits. Where are your social skills right now? Are you interested? Hi, sorry, I don't know what happened. I guess it kicked us out. I'm going to share my screen again. Okay, perfect. Cynthia said she can see and hear me again, so that's good. Okay, so sorry about that. Okay, so talking about social skill deficits, we want to meet you where you're at. Are you comfortable around other people? Are you averse to other people? Are you interested but you're not sure how to interact? Or are you dominating conversations? You're not sure how to have that reciprocal back and forth. We want to determine where your social skills are, and also what are your goals for your child, and kind of go from there. Rote and restricted behavior can really refer to a lot of things. It can be maladaptive behavior, aggression, self-injurious behavior, and things like that. But it can also be things like, my child doesn't like to wear pants. They only wear shorts and short sleeves. Or when the weather changes, it's a battle to get them to wear jackets. They hate turning off the lights. They don't like to use toothpaste. They don't want to change, what they're doing unexpectedly. If I tell them like, hey, we have to go right now, that's a battle. So unexpected changes are hard. Or hey, anytime I take away the iPad, it's a meltdown, and it's not like a typical meltdown for everybody else's kid. It's a huge battle. So rigidity, things like that. And a lot of the maladaptive behavior goals are often related back to communication deficits. They can't tell us what's going on, or the rote and restricted behavior. And we want all of our goals to be socially significant. Goals have to be and need to be meaningful to the client and to the family. If I have an older client who is unable to express his wants and his needs and is not independent, I'm not working on community helpers. That is the last thing we need to be working on right now. We need to make sure that that child is able to, do all of the skills needed to help himself. And we also want to make sure that he's able to communicate and do all the things that he needs to get done. Additionally, we want to make sure that all of our goals are measurable. The Medicaid guide is very clear that everything needs to have a baseline. What is their current level at? What is the intervention that we're going to put in place? And then what is our plan for maintenance? And we also want to make sure that our goals are attainable. If your child is currently just pointing to gain things, then our first goal should not be speaking in sentences. Our first goal may be that we are going to pass pictures to request things, or it may be that we're going to work on repeating initial sounds, or it may be that we're going to use a speech generating device. We want them to be attainable, and scaffold upon one another in order for them to access things. And then we may be writing behavior support plans to reduce those interfering behaviors wherever applicable. And then finally, we want to get consent. We're going to fully review the treatment plan with parents and make sure that it's approved. And then we also are going to review our treatment plan with the clients if appropriate and get their consent or assent as well, because we want to make sure that they have that buy-in as well. So we review it with them, review their behavior support plan, so that we're all on the same page. So what does treatment look like? So sessions are going to be individualized. They are one-to-one primarily. We're working on communication, social skills, behavior reduction. They're super fun. We try to make them very play-based. They may be in the clinic, they may be in home, or they may be community-based. There are group codes available. And so many clinics are doing social skill groups, or they may be times where they're doing 2-to-1 or 3-to-1, but primarily ABA is a one-to-one based therapy. For parent training, we are working on individualized goals. They should be meaningful to each caregiver and they should be sustainable. And during my initial meeting, I usually like to say, what's your worst 15 minutes of the day? Okay, let's work on that. And for some parents, it's the morning routine. I can't get them out the door. I can't get them out of bed. And for some parents, it's, the nighttime routine. For some parents, it's trying to take preferred items away. You name it, I've heard it. I also have a child and it can be really difficult. No one expects perfection. And we also have, tips and tricks and all the things for, hey, if today's the day you have a migraine or dad is out of town, or whatever is going on, today's not the day that we're going to, work on something new or start new, brand new things. Today is the day that we are just going to make sure we all survive. And here's the tips for the today. Again, exclusions are we should not be teaching academics and insurance or Medicaid funded ABA programs. It's not for respite or in-school support or custodial care. So ABA services at MeBe. ABA at MeBe primarily is in-home therapy right now. There's a BCBA overseeing the therapy, and then a team of highly trained RBTs. Our session times are from 8 a.m. to 7 p.m. Your child is not getting 11 hours a day of therapy. Don't worry. Those are just the times between which you can choose. We have some parents that are like, I will never be up at 8 a.m. and some parents that are like, come on in, we're awake. So it just depends on what works best for your family. I have the minimum amount of time our kids receive therapy is between 10 hours a week to 40 hours a week. We have clients that are in school, so they get about 10 hours a week. They're primarily working on social skills, all the way up to kids who receive ABA in lieu of going to social school or going to school. So they're primarily younger, or they may be a little bit older, and they receive about 30, 35 hours a week. We are credentialed with Medicaid and all managed care organizations. ABA at MeBe, we're a premier provider ensuring every child has immediate access to ethical evidence-based therapies. And we try to say that, or we say that ABA at MeBe is serious fun because we try to say that, you know, the biggest, most important thing is that our kids are not sitting at a table just working on table work. We want it to be fun. We want them to experience learning in a positive way. We don't want it to feel like work. And so I love going to work and having fun with our clients. Sometimes I'm out of breath from running around chasing them all day, but it is super fun. Yesterday, one of my clients made a bet with me that if he had a perfect day, I would hold his frog at the end of therapy, and he did have a perfect day, and I unfortunately had to hold his frog. So, you know, every day looks different. That's what's fun for him, not me. So we do have a lot of fun in sessions. Our intake process is that you can contact MeBe through our contact form or via phone. And then one of our family success leads will contact you, and they really walk you through the whole process from beginning to end. They're contacting you, and they'll contact you in whatever way you like to be contacted. If you like to talk on the phone, they'll call you. You want to do email, they'll email you. You like to text, they'll text you. And then I also enjoy staying in contact with my families, so I'll contact you regularly as well. They will run your benefits through Medicaid or insurance, whatever it may be. Ensure that you have all the information and that you're well aware of it. Once you're ready and approve of that, they will go ahead and run an authorization. And then once I have the authorization, I start the assessment. Once the assessment is completed, sessions are initiated. So that is the process. From getting the FBA authorization to sessions, it's usually about 4 weeks. We are excited to announce that we are opening a new learning center in the fall. It'll be in Northwest Houston, and it will have a learning center, and then we will also have social groups there. So that is super exciting. Some resources I wanted to share is that on CASP, which is the Council for Autism Service Providers, if you even just, you know, Google Texas Medicaid and CASP, there is a webinar and downloadable slides all about Texas Medicaid. They have been super instrumental in really working to make sure that Texas Medicaid was approved and that it's also sustainable. TexABA, which is the Texas Association of Behavior Analysts, also they have a public policy group, and they also have done a ton of work to ensure that Medicaid also went through, that it had sustainable reimbursement rates, and they have the timeline of everything that's happened, and they have a lot of links in their website to things that may be helpful or important. For Katy Autism Support, which we're so thankful that they helped us put this webinar together, they have the website, katyautismsupport.org, and also their Facebook group is phenomenal. Katy Autism Support Discussion Group is on Facebook. It is super, it just has so much information, and I know that it has been helpful for parents for so many years. And I really encourage you to join that group if you're not in it, to just get so much information. It was very helpful. And so now I'm going to open it up for questions. I'm going to kind of close that. Let's see. Are there any questions? Anybody have any questions? No? We went over a lot today, so. Yes, the process can be very complex to get started. And then the credentialing process is also quite long. So I believe they updated their credentialing like system in December. And initially organizations were not being credentialed. It was just providers. And so we had to wait. We had providers credentialed, but not our organization. So now our organization is finally credentialed. So it has been a lot. So we are very excited. So typically, once we have clients that have signed up and they're interested, it takes, I would say, about 3 or 4 days for everybody to get their information in, like their Medicaid card and their information. We run a verification of benefits. The verification of benefits will let the families know how much, they will pay per day or per week. And then we'll contact the parents and let them know. As soon as we have that approval from the parents, then we send in an authorization request for the functional behavior assessment or the assessment auth. As soon as we get that back from Medicaid, I then have 3 weeks to complete that. So that process takes about 4 weeks. And as soon as we have that, so it usually takes from them contacting us to us having the full approval, I would say 4 to 6 weeks. Now that depends on if we have a wait list. We currently have a short wait list, but I'm hiring BCBAs to help with that. So we're taking clients on this wait list to very quickly start them. So and the more people we add to it, the more BCBAs I can hire. So, but yeah, typically only 4 to 6 weeks. So I see that we have a question and answer. Are you in Dallas from the anonymous question and answer? I think Cooks is from AmeriGroup. We should. Yes. We will be in network with all MCOs. It does not matter what area you're in. I'm in Houston, so I only know about like Texas Children's and all of that. But yes, you don't have to ask Medicaid for that. If you have AmeriGroup or Cooks through Medicaid, then yes. And our Dallas area has a significantly shorter, I don't know that they have a wait list at all. So you could go to our website and put your information in, and they would be able to answer you quickly. All right. Thank you all so much, everybody. Y'all have a great afternoon, and please feel free. I'm going to put I guess I have to go back here. There's my contact information. Oh, maybe I didn't put my contact information up here, but my email is Nicole, Nicole .cl@mebefamily.com. And you can email me anytime. My email is also, you can find me on the website. But you can email me anytime. And I would be happy to answer questions. Thank you so much.